This is called the temporal mandibular joint. And so the lower jaw is connected to the cranium in this area. And so the lower jaw is, while the maxilla has a bony connection, the lower jaw articulates. It opens and closes. You all know that. And this is the hinge around which it opens and closes. But what many don't know is that in childhood, one of the growth centers for the mandible is at the head of the condyle, which is this ball joint. And if there's any type of injury or accident with a child and even an adolescent, it can impact the growth center such that you don't get fully expression of the mandible growing forward. How would you see that? People that have buck teeth, in other words, the upper jaw is out in front of the lower jaw, perhaps the problem is in the joint. And so this expression of an overjet and open bite can have its etiology in that the head of this joint is the growth center's been impacted by an early incident. And so orthodontists can be down here treating teeth and, God forbid, taking out teeth to retract the upper so that you don't have an overjet. And the problem could be on the whole other side of the mandible. So they're treating the teeth and the etiology could be the joint. And so it's just really important that we understand that airway issues, so often dentists are involved with straightening teeth, but the teeth are just an expression or a symptom of the problem. And that's my point. So if you see crooked teeth and you see orthodontics, red flag, why is there a growth and development problem going on in this child? Is it because they're mouth breathing? Is it because they're only eating soft foods? Do they have a problem with their temporal mandibular joint? And so we have ways of imaging the joints now. I mean, dental offices didn't used to have CAT scans. And still most don't, but numbers do. I mean, I have one, Scott, you have one, and so I don't know what the percentages are, but with that, you know, in 7 seconds we get a scan and we can look at the joints and know if we think there's a problem. If we need more imaging or we want to look at the disc, we can get an MRI, which you have to send out for because that's over $1 million piece of equipment, but this is around $100,000. Now that you understand a bit about the structure, I just, through Sydney's story, want to help you understand a bit more about diagnosis and treatment, because everybody always wants, I'm sure you run across it, they want to jump to treatment. So what do we do about it? And the key is, what's the diagnosis? Because we jump to treatment far too quickly before getting an accurate diagnosis, and in airway, this is a significant issue. So with Sydney, this is her picture at age 12. Now recognize she had already started orthodontics at age 8 with upper expansion. And if you look at this V-shaped narrow palate, you wonder what did they expand? And then, but look at the face. You guys are already seeing it. Her lips are apart. Her lower lip is full and heavy because she hangs it open. And her lips are dry, and so she's a mouth breather. Her tongue hangs down low. It never fills the palate and develops the right arch form. So and I'm part of the problem. You know, I didn't get the training. That's why I'm on this mission to change the training. So I didn't do ortho at the time. I took it to what I thought were good orthodontists, and they did what they learned, and they straightened the teeth, but never addressed the underlying cause. And so I want you to observe your patients. You know, to every mom, their child is the most beautiful or handsome. They can do no wrong. And that was Sydney. I don't think of Sydney as a grumpy child. She was a great little athlete. And when she was grumpy, we just felt she was hungry. And most of the time, we gave her some food and she got better. And we gave her the wrong foods, Liz Locialo, I'm sure of it. But, you know, if I knew more, I mean, drawing this called a Bolton norm, but basically I just want you to see that her lower jaw is already back too far. It should be on that line. And it looks like she has what we call a weak chin. But look at the face on your right. I mean, that's a tired face. And so we just need to observe our patients. And that's why Sydney said, sometimes you just Forget what the test results said. Listen to the patient. If it doesn't look right, it's not right, and you need to encourage the parent to keep digging. Because if we didn't keep digging for Sydney, the rest of her life would have been far less than what it's going to be. And, you know, parents, there's me with my mouth open. I'd like to say I was probably just talking, but, you know, the parent history, I snored as a kid. They said I snored so loud that I'd wake up the house. It was just a joke. You know, that's what we thought was funny. I couldn't stay awake in class. Throughout, I loved class. I'd always be right in the front row. In dental school, they have pictures of Victor sleeping in the front row. And I didn't realize I had a sleep disorder. I was so excited to learn, and no matter what I did, I could not keep my eyes open in class. And so, you know, the parent history is important. And I just show you these because I know when Sydney said the doctor just needed to look at my face and they knew there was something wrong, and you had to be looking at Sydney's face and saying, it's a darn pretty face. Well, that Sydney was this Sydney. And so her face has been transformed by maxillomandibular advancement surgery and nasal surgery. But this Sydney's face grew out of the environmental factors that Dr. Park will speak about. But you can see when you look at her, you just about can see the whites of her eyes, which is the indication that the maxilla is dropping down and back. If you drew a line down her nose and a line from her lower eyelid, they would be divergent. And so it's basically the mid-face not developing forward, again, because the tongue not being up, creating this wide palate, which would create wider cheekbones. And then, you know, always looking at lips if they're dry. You know, in the winter, everybody's dry because it's, you know, it's the environment, it's the heat. But you can tell when it's just that, or you're treating them in the summer and they're still dry, it's because they're mouth breathing. And by the way, people that are mouth breathing are going to have more decay because they're changing the pH in their mouth and it's drier, and they're going to be much more susceptible to cavities. This is Sydney's first CAT scan. We call it a CBCT, cone beam CAT scan. And when we measure her airway at 164, this is back in 2016, very much in the beginning of this diagnostic process. This is a study. Hatcher is a radiologist. He owned Beam Readers, which is a national radiology reading company. So they read thousands of CAT scans, hundreds of thousands. And so they have a large study where they looked at, could they correlate the size of the airway where it's minimally constricted from the soft palate down to the epiglottis. And if they looked at that, could they correlate it with obstructive sleep apnea, which is only one type of a sleep disorder. What I wanted you to see is that Sydney doesn't even fall into a category. She has, based upon that number, a low risk, because she's greater than 110. She has a low risk of having severe obstructive sleep apnea. Christian Guilleminault, who came up with mild, moderate, and severe in the latter days of his life, he died last year, said it was the worst thing he ever did. He should never have given mild, moderate, and severe. If somebody is obstructing, consider it a severe episode, even if it comes back mild. Mild is something now the insurance companies have jumped upon as a reason to give dollars for treatment or deny dollars for treatment. It's not about Sydney as an individual. So Sydney doesn't qualify. She doesn't qualify for anything. Based upon the CAT scan, she's not in a high-risk category. So the key is it's a dynamic airway. It's lined by soft tissue. It collapses because of gravity when we lay down at night, and there's all these other factors in terms of inflammation that can affect that airway. And remember, if there's a constriction anywhere along the airway, just like if you had a garden hose and you stepped on it, you'd have to turn up the volume to get the water to still come out the other end. If there's a constriction, whether it be in the nose, the soft palate, the tongue, or the epiglottis, you have to turn up the hose, which is your diaphragm, to get the air in. That can be very disruptive to sleep. And so people that have sleep disorders may not obstruct where they completely stop breathing, but just the increased effort to breathe can be enough to cause their sleep to be interrupted or fragmented or just plain not restful reparative sleep.